I'm used to talking to NAMI groups and talking about serious mental illness because my time here in Boulder these last 40-some years has been spent working 30 years at the Mental Health Center, primarily with people with very serious mental illness, and acutely so. And then the last 10 years, we started a program called Colorado Recovery, which takes the same sorts of customers from across the country, people with serious mental illness who have failed to do well in treatment elsewhere. And we find that most of our patients come to us with a diagnosis of schizophrenia, but when they reach us, they often have been re-diagnosed by us into bipolar disorder or affective disorder, such as unipolar psychotic depression. And so that's one important aspect I want to cover tonight. The other is the question of the underdiagnosis and the overdiagnosis of bipolar disorder, which is a strange situation to find ourselves in, but it's true that both things are happening simultaneously in this country at the present time. So just a quick summary, and by all means interrupt me at any time that you need something explained. Quick summary of the history of bipolar disorder, or manic depressive illness, as we used to call it, is that it was determined by Emil Kraepelin in Germany, in the asylum he worked in the 1880s, that people coming in with psychosis could be categorized into dementia precox, which was his term for what came to be called schizophrenia, and manic depressive illness. And that was the state of play for all the years since then, until during the 30s and 40s and 50s, in the United States, there was an invasion by Freudians, and psychiatry got taken over by the Freudian impulse, and most of the psychiatrists were in fact trained as psychoanalysts, and they were more interested in internal processes and not so much in categorizing illness and determining symptoms and signs and looking at them in a scientific way. So what happened was that in the United States, through the 60s, there was a strange phenomenon that in the United States, nearly everybody with bipolar disorder was diagnosed with schizophrenia, whereas in the rest of the world, people with bipolar disorder were being recognized as such. And this was shown by a study in which a team of psychiatrists came from London to New York and examined patients in New York, and a team from New York who went to London and examined patients there. And it was demonstrated that this was a complete switch, as it were, in the diagnostic approach. That the United States had this very broad definition of schizophrenia, which included people with bipolar disorder, which wasn't the case elsewhere in the world. Could you bring me my glass of water? Thank you. Now, a big reason for this was that lithium carbonate had been discovered to be effective in bipolar disorder, manic depressive illness, by an Australian psychiatrist in 1949. By the late 50s and 60s, it was in widespread use across Europe and the rest of the world. But in the United States, there was no lobby pushing for lithium to get introduced into practice. And it was, in fact, not recommended for use by anyone because it had previously caused heart problems when it had been used as a salt substitute for people with physical disorders. So the reason that lithium wasn't available and that this diagnostic difference continued for a decade was because there was no money to be made on selling lithium because it's the most simple substance you could wish to find, the same simplicity as table salt, lithium carbonate, sodium chloride. And so there were no drug representatives marketing it and getting people to form a group to try and get the FDA to approve it. But finally, there was an advocacy group of people with mental illness and their families, which got the FDA to bring it in on research stages in 1970. And then in the next 10 years, the United States suddenly started recognizing bipolar disorder. And by the end of that 10-year period, 1980, the DSM-3 changed the diagnostic criteria for schizophrenia from the broadest in the world to the narrowest. And suddenly, we were treating bipolar disorder as we should. Now, the next fascinating step was the discovery that not only does lithium work as a mood stabilizer in bipolar disorder, so also do the anticonvulsants previously used for epilepsy. And how did that discovery get made? It's one of those amazing pieces of intuition that somebody had, looking at the course of somebody with bipolar disorder over a lifespan. Nothing, 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 an episode of depression, episode of mania, depression, depression, mania, and then later in life, repeated episodes happening so fast that there are 3 episodes or more in a year, which was called rapid cycling. And somebody looked at that and they said, oh, if instead of that being a lifespan, that's a day or 2. That's what epilepsy looks like. An epileptic fit will make your brain so excitable, it's more likely to have another episode immediately afterwards, getting closer together and more frequent. And so Post, who was working at the NIMH at the time, started treating people with Tegretol, which is one of the anticonvulsants, and discovered that yes, it was a great treatment for rapid cycling bipolar disorder, but also it's effective in all phases. So suddenly the drug companies had something that they could market, and they started coming out and talking to psychiatrists about using the anticonvulsants as the drug of choice for bipolar disorder, and they are in fact very effective medications. But as a result of there being no drug reps for lithium, over the course of subsequent years, lithium has gotten sidelined. Now, in fact, lithium is the most effective drug for treating bipolar disorder. A recent study in the British Journal of Psychiatry shows that if you're in your first episode and you're given lithium or given Tegretol or Depakote, lithium is more likely to be successful if it will stand alone for the treatment of the disorder. But often the two mood stabilizers together can produce excellent results. Now, then a strange thing happened, that some psychiatrists at Harvard started looking at children who had very volatile moods that fluctuated through the course of the day, and they said, oh, well, this sort of is like rapid cycling. Maybe they're a kind of form of bipolar disorder. And they started prescribing anticonvulsants and antipsychotics for children, nearly all of whom had attention deficit disorder, but diagnosing them with bipolar disorder. And as a result of that movement of diagnosing volatile moods in people where they fluctuate through the course of the day, over the next few years, the prevalence of bipolar disorder as diagnosed in the country leapt up by a factor of 40. So now for every 40 people labeled as having bipolar disorder, 39 of them actually have something rather different. Not true bipolar disorder with psychotic features. So this creates a problem of a sort. The medicines may have helped the children, they may have damaged the children. The problem was, of course, that the Harvard psychiatrists are found to be in very close association with the drug company Johnson & Johnson, which can produce Risperdal. And they got into trouble because they hadn't reported to the officials at Harvard just how much money they were getting from the drug company. So there was a scandal on the front page of the New York Times for several years around 2008. The problem is partly that so many people are getting treated with powerful drugs, but also if you try to go out and educate the police, as we used to do at the mental health center, or go out and talk to children about mental illness and educate them about serious mental illness. You talk about bipolar disorder as this psychotic condition with very extreme forms of behavior, very high rate of risk to the people who are suffering from it. And a policeman in the group will hand up all of his hand and say, well, my son's got bipolar disorder. And another one holds up his hand and says, my son's got bipolar disorder. Or you're in the school and 3 or 4 kids hold up their hand and say, but I've got bipolar disorder. Well, this is the problem if we're calling different things by the same name. You can no longer use the terminology that you used to use. So it made education very difficult. And the latest edition of the Diagnostic and Statistical Manual has changed the description of this disease in children from bipolar to, I think, temper dysregulation syndrome or something of that sort. So it has been corrected, but we've still got this situation with many people with maybe adults with certain personality disorders or children being told they have bipolar disorder, but they really have something different. So that's the overdiagnosis bit. The underdiagnosis bit is also very serious, and it's not related to what I've talked about so far. I think it's related to the speed of dealing with people who get into hospital with a psychosis, and the insurance regulations that say, well, we'll give you 5 days authorization for this admission, and all right, maybe another 2 days after that, and the patients are being rushed out, and the hospital staff are being driven to treat people as fast as they possibly can. With the result that doctors say, well, here's somebody he's hearing voices, and he's behaving in an agitated way, it must be schizophrenia. We'll put him on antipsychotic drugs, because they know the antipsychotic drugs, whatever the condition, will have an effect, will calm the person down and control him or her to a certain extent. And then they're out the door with a diagnosis of schizophrenia or psychosis NOS. And there are so many of these cases now that we get from around the country. It really pains me to see what the practice of psychiatry is like in certain parts of the country and in certain townships. For example, we just had somebody come to us who is diagnosed at the hospital in Minnesota with schizophrenia or bipolar disorder, or what was the third one? Schizoaffective disorder, on antipsychotics and antidepressants. And the person was in fact manic. And so antidepressants were totally the wrong thing to be giving the person. So this failure to spend time evaluating the person is a tragedy, really. And what it takes to do it right is to have the family there with the person, to start at the beginning, and to look at the illness in a sequential manner, over the span of the life, and not just in a cross-sectional way. Well, you look so-and-so to me today, so take this. Now, the big problem is the failure to really look at the content of the hallucinations and delusions that the person is presenting with. That there's too much of a tendency to say, oh, hearing voices, I'll check that box, auditory hallucinations, and then moving on to the next, without saying, so what are the voices saying to you? Or what are these delusions that you have? So you feel frightened that somebody's after you, and then not going on to ask why somebody would be after the person, what would be the reason for doing that. And in fact, there are some key components to a depressive psychosis, whether it's bipolar or unipolar, that really yell depression. There are components like preoccupation with death, disease, or guilt. So preoccupation with death, just had somebody in last week who thought he was dead, and thought he was dying, and thought he'd left his soul. So that was the death part. The guilty part was he felt that he had failed humanity by not measuring up to humanity's standards and somehow being separate from humanity. And disease, let's think he didn't have disease. I had somebody within the last week have the delusion that she definitely had cancer, even though it had been ruled out by everybody who had studied her for cancer. You find people who feel guilty that something they did when they were 15 has now caused the police to come after them. They're going to arrest him and all of his family and lock them all up and be in total tears about it. So ignoring those elements and ignoring the surrounding context, like crying or thinking about suicide, these things get left out of the picture just because of the urgency to do an evaluation in half an hour, get the medicines, get out. And this is happening across the country every day. So it's really a sad picture, I have to admit. It's not true everywhere. There are some very good hospitals, all the community hospitals doing a great job, it's my impression. But it is a tragedy when you meet somebody who's had this illness for 5, 10 years and has never been treated with mood stabilizers. And we get that all the time. Or because lithium has been sidelined, never been treated with lithium, and we get the opportunity to treat the person with lithium, and that's one of the fastest working drugs in our pharmacopoeia. 2, 3, 4 days, the person is better after 10 years of a tragic life. So that's overdiagnosis and underdiagnosis going on at the same time, sort of different domains. So happy to take any questions if there are any. Yes, sir.
So what's on the forefront for bipolar disorder going forward? Are there new medications coming out?
Well, what I'm encouraging us to think that should be on the forefront is better provision of services, better training of psychiatrists, more time to work with the patient, do the evaluation, more emphasis on bringing in the family to help spell out the history of the person's illness, so that mistakes aren't made, and a recognition that it's in fact easy to include families in these kinds of evaluations, even if the patient is not willing, because families can tell the psychiatrist anything they want, and that's not a breach of confidentiality. It should be part of standard practice to do that. As far as new drugs, the greatest introduction has been the discovery that Lamictal, which is one of the mood stabilizers from the anticonvulsant world, is remarkably good at helping people get out of the depressive phase of bipolar disorder. And that's been true for 10 years, but it's a real addition. Yes, ma'am.
What percentage of your patients would you say do not tolerate lithium?
Almost none.
Almost none.
Almost none. So that's another thing that's happened, is that somehow lithium has gotten a bad rap for not being tolerable, but it's in fact one of the easiest medicines to take. I'd take lithium without a concern. We know the serum level to go for, and when you've got the right serum level, it stays the same for decades.
The reason I ask is because my daughter's bipolar, and she was not able to tolerate the lithium. She does take Lamictal and run, and found that she does better on those.
I'd have to know what the side effect was. But lithium can appear to cause problems, but if it's given with an antipsychotic, which it often is, it can bring out the side effects of the antipsychotic much worse. Stiffness, shakiness, and restlessness. The solution there is to cut down the antipsychotic. Yes?
You say there's been overdiagnosis. Are you also, does that imply that it's also misdiagnosis? In other words, the drugs that have been available to treat severe fluctuations, are they perhaps not the right drugs for the right illness? So is it not just an overdiagnosis, but a misdiagnosis, and therefore the drugs that were available weren't really adequate for the problem?
Well, the overdiagnosis are those people who've been labeled bipolar who've never had any psychotic symptoms, but have had mood fluctuations due to some other cause, but through the day, and not 3 cycles of manic depressive illness per year. There are many good doctors, good psychiatrists in Boulder, who adhere to what's called the bipolar spectrum view of the disorder, but I'm not one of them. I think that is overdiagnosis and causing us problems. And when we pick up the phone and somebody says, we'd like to come for treatment with you, our daughter has bipolar disorder, we always have to ask, now, is that bipolar disorder with psychosis or without? Because we treat people with psychosis. And many people who have been diagnosed with bipolar disorder have something different. But being an old English person, I don't recognize as being bipolar disorder or manic depressive illness. Oh, yes.
How frequent is the mixed state in this disorder in terms of percentage that you see in your practices?
Well, a mixed state, when I was in training, was recognized as what's called a dysphoric mania, meaning that it's mania, but the person doesn't enjoy it at all. The mixed state that other psychiatrists refer to probably is more appropriately applied to people who don't have bipolar disorder with psychosis. So I don't see anyone that I call a mixed state. Sometimes I scratch my head as I see somebody going from depression to mania in the space of a couple of days, because that can happen. And so there is a transition period, but it's quite alarmingly fast often. Usually I can say, yeah, I see why this would be called a mixed state, but it's a manic state and the person hates it, so we'll treat it as mania. There are many other psychiatrists in town who would not follow that practice, but that's my approach. Yeah.
What do you think about children and the diagnosis of bipolar disorder?
Well, some children can get bipolar disorder, and many of the kids, of the adults that we see, had their first depressive episode, shall we say, when they were 15 or 14 or 16. And so the illness does begin then. But the vast majority of the kids who are diagnosed with bipolar disorder, in fact, have attention deficit disorder, and the mood volatility relates to that. And there are ways of treating the attention deficit disorder effectively with stimulants and other drugs to minimize the mood volatility, the explosions and the anger. But I certainly wouldn't want to say there are no children with bipolar disorder. There are probably plenty. Mostly one sees the first episode of mania happening in college, but for some reason I think depressive episodes are more common earlier in high school, and produces marked changes that often don't get diagnosed at that stage. Did that answer it?
Yes, and what do you think about even younger, say, under 12?
I don't think I've ever seen an adult where the first episode happened before the age of 12. And we've got to remember that a lot of these kids who are diagnosed with bipolar grow up and go to an adult psychiatrist, and the adult psychiatrist says, well, this isn't bipolar disorder, like I learned about it. And the diagnosis changes after the age of 18. Yeah.
For very complicated cases of bipolar disorder, where's the best place, in your opinion, in the country to go for someone who doesn't tolerate a lot of meds, who maybe has built up tolerance to some of the meds, things like that?
Well, I'm not allowed to say this, but Colorado Recovery would be one. I'd say Menninger, but I'm not sure they do the best job. They certainly do an impressive evaluation. Alicia, where would you say? But maybe here, so he's Sutherland Center.
Well, I was for generous, not on recovery, so.
I'd probably taken too long, so let's cut it off there. And thank you very much for your questions.